So today I have lots of talk. My contents are like this: terminology, endoscope, specification, about probe curve, assistant duties. In this field, assistant work is very important because we cannot perform endoscopy just by myself. Assistant co-work is very important. And finally, I hope I could give you clinical advice for beginners. So let me start with terminology. Diagnostic dacryoendoscopy gives us visual information inside the lacrimal passage, which is called direct visualization. Direct visualization is the most important keyword in this field. Originally, this word was coined by Dr. Cohen in 1979, 40 years after his development. Now we have a fibertech lacrimal endoscope like this. Using this endoscope, we can see various findings in the lacrimal passage in various conditions. Among those, I'm going to let you know the most basic findings, like this. When you insert lacrimal endoscope in the lacrimal sac in a precise alignment, you can see this kind of a gap comprised of medial and lateral wall of the lacrimal sac. Basically, this finding can be seen only in the lacrimal sac with no stenosis in the duct. We call this sign slit sign. So the slit sign gives us very useful, clinically useful information about endoscope orientation and duct condition. Basically, inside the lacrimal passage can be seen just like hole everywhere. Hole. Canalicles, lacrimal sac, nasal lacrimal duct, everywhere can be seen like a hole. So sometimes orientation, endoscope orientation is very difficult. Sometimes, especially when performing therapeutic dacryoendoscopy, the orientation is very difficult. At that time, when you see the slit sign, then the finding gives you the confidence. Oh, I am in the lacrimal sac now. This is point. And the second advice is, at that time, you don't have to go further because slit sign can be seen only in the lacrimal sac without any stenosis in the duct. So there is no need for going further if you can see the slit sign in the lacrimal sac. So in that meaning, slit sign is very important. And sometimes we can use this slit sign as a surgical landmark. Look at this example. The diagnosis and pre-op diagnosis was nasal lacrimal duct obstruction. Left side shows pre-operative endoscope image. You can see pinhole-like finding here, but syringing test shows no pattern. So this is nasal lacrimal duct obstruction. The pinhole is something like an entrance of the fibrous tissue here. And after reconstructing surgery using microendoscope, using lacrimal endoscope, you can see the lacrimal stent here, and after the reconstruction, you can see the slit sign here. So that slit sign tells us the reconstruction was perfect. So when we perform the reconstruction surgery using lacrimal endoscope, we have to dissect the fibrous tissue until we can see the slit sign. So let's move to the therapeutic dacryoendoscopy. Therapeutic dacryoendoscopy allows for reconstruction of the physiological tear outflow system without creating a bypass, which is called recanalization. Exactly speaking, Dr. Hubbard, based in Manila, called his procedure ELDR, or endoscopic lacrimal duct recanalization. Dr. Sander in Singapore calls endoluminal lacrimal duct recanalization. Sometimes I use microendoscopic recanalization. A little bit different according to the surgeon, but keyword is recanalization. Originally, the recanalization concept was developed by Dr. Emmerich in 2000. He is using special device such as a laser probe or micro drill, and he defined his procedure as minimally invasive lacrimal surgery. However, without using such a special device, we can perform the same minimally invasive lacrimal surgery using fiber-tape lacrimal endoscope with some kind of a simple device or simple technique. I'll let you know the several techniques and devices. The first one is DEP, direct endoscopic probing. This is very primitive technique for the recanalization. Just pushing the membrane using this endoscope. No need for other device. Just endoscope is required. Just pushing. This is example of common canavicular obstruction depth. Exactly speaking, we can see the pinhole here. So this diagnosis, pre-op diagnosis was common canavicular stenosis, I think. And we are in the common canaviculus now. What I'm doing is just pushing this membrane. And I can break the membrane here. And after recanalizing, I can get into the lacrimal sac. And what I can see is slit sign here. So in this timing, the endoscope tells us that I performed precise recanalization without causing a false passage. And the duct condition was fully patent. Very important message. This is very important. So after that, I can intubate, and the patient is going to be happy. So then, what should we think if the slit sign is not visible? So CCO depth without slit sign. At that time, there are three conditions we have to think about. The first one is physiological condition. This is no problem. Physiologically normal duct without Hasner's valve. Usually, ostium of the duct has Hasner's valve like this. But sometimes a patient doesn't have Hasner's valve at the ostium like this, just like hole. In this condition, the air is coming from the nasal cavity to the duct and going up to the lacrimal sac, and as a result, we cannot see the slit sign. This is an example. Pre-op diagnosis was common mechanical obstruction. We can see dimple here, dimple, and just pushing the dimple. This is depth technique. after breaking the membrane, we can see air beyond the obstruction membrane. This is a large air bubble which is coming from the nasal cavity, and we cannot see slit sign. This is no problem. But second condition is a little bit problematic. We have to think about ductal condition such as obstruction, stenosis, dacryoleaf, or dacryocystitis, something. I'm going to show you one example. I'm in the common canalicus, and targeting the dimple, I'm pushing the endoscope tip. After depth, what I can see is not slit sign, but a dirty pus. So this patient has common canalical obstruction complicated with dacryocystitis. So in that case, of course, we can perform intubation here, but the long-term success rate for such case is not good. So, in my opinion, DCR is better for this case. The next one, the final one is very problematic. This is a critical problem we have to think about. So personally, I don't want to talk about this one, but for the safety first, you should know this problem before using fiber-type lacrimal endoscope. I'm going to show you one example. This is common canalicular obstruction. I performed that, and I'll show you the video. I'm in the right side common canaliculus, and what I'm doing is depth. After breaking the membrane, I cannot see the patent lumen, and what I can see is just whitish space surrounded by fibrous tissue. There is no slit sign. In this time, I don't have good feeling, so I discontinue. And 2 weeks after that, I redo the depth for the same case. So this time, I can easily broke the membrane, and I got into the lacrimal sac, and I can see the slit sign. So this case tells us that the first depth was false passage, and the second depth was this is a good depth. So let's summarize this case. In the first depth, the endoscope probe was proceeding in this track. If I didn't continue, if I didn't stop, if I continue, then maybe I will be able to get into the lumen somewhere. But I discontinue. At this timing, someone may think about lacrimal sac fibrosis, but the chances of lacrimal sac fibrosis is very rare. Almost all, a majority of the that kind of a case shows not lacrimal sac fibrosis, but a false passage. And a true lacrimal sac lumen is existing just beside the false passage. And the first depth is migrating into the lateral wall of the lacrimal sac. This is false passage. I call this situation, this condition, missed sac. The lacrimal sac was missed. As I'm going to show you the other example of missed sac. Pre-op diagnosis was common canalicular stenosis. On the right side, lacrimal passage. I'm doing depth, but after breaking the membrane, I cannot see the slit sign. What I can see is just whitish space surrounded by fibrous tissue. I performed DCR for this case. And this is transnasal view using a nasal endoscope. And this is pre-op diagnosis was common canalicular stenosis. So lacrimal sac lumen was stained by fluorescent dye coming from the stenosis portion. So we can see the stained lacrimal sac mucosa like this. And surprisingly, oh, no, surprisingly, illumination of the fiber scope can be seen like this. So this is a great evidence that lacrimal endoscope is migrating into the lacrimal sac wall. So be careful. Common canalicular obstructional stenosis is one of major times this happens. Sorry, and there is more serious case. When the patient's canaliculus angle is very steep, sometimes we can encounter this kind of patient. The canalicular angle is very steep. In this case, there is a possibility that the endoscope perforate to full thickness perforation to the orbit. In that case, we can see the vessel palpitation or adipose tissue. This is a serious false passage. So, false passage in common canalicular obstruction depth include missed sac and canaliculus perforation. The mutual sign is no slit sign. So that's why I said slit sign is very important. And originally, the term slit sign was coined by me. I wrote the slit sign about slit sign in Japanese journal in 2003. Since then, this word has been widely distributed in our community. So you can use this slit sign. But I didn't write an English paper. You write. Okay. I'm not so good at English. And if the false passage occur, we should discontinue. If continue, maybe there is some problem, including acute or chronic inflammation. But if you discontinue, no problem, and wait 2 weeks, then you can try it again. So the next thing I want to talk about is a very simple device, sheath. This is very useful. We can use sheath. We can make sheath by ourselves. In our country, 18-gauge intravenous intervening catheter is available. Is this same thing available? Oh, yes. Okay. Then you can make this sheath using this. Cut the end of the catheter and make a split here and fit it onto the endoscope probe, and we can use this as a lacrimal trephine when performing recanalization. Or we can use this intubation guide when performing intubation. This is very useful and very cheap. And the rest are SEP and SGI. SEP stands for Sheath Guided Endoscopic Probing. This is a kind of refined technique for the probing. DEP is a very primitive and simple technique, and SEP is an upgraded technique using sheath. So we need sheath for performing a SEP. And SGI stands for sheath-guided intubation. For performing sheath-guided intubation, of course, we need sheath. So these procedures are performed sequentially, usually. So we call this sequential technique SEP and SGI. SEP and SGI is main procedure in the therapeutic dacryoendoscopy in our country. This is very popular. Every ophthalmologist is very familiar with this technique in our country. So this is at surgical step of the SEP, and this is surgical step of the SGI, but I will skip this because today's my focus is on the diagnosis, as I let you know in the program. So this is a recap slide. I talked about direct visualization. This is the very important word. And the slit sign is very important. And recanalization was developed by Dr. Emmerich, and this is key concept of dacryoendoscopy. And the sheath, SEP and SGI. So let's move to next topic. In this section, I'm going to talk about lacrimal endoscope specification. I developed this endoscope in 2001, and the governmental approval was given in 2002. Now we have two models. Exactly speaking, there's another lacrimal endoscope which has the stretch probe, but usually we use these two types. One is MT3 and the other is MD10. MT3 has a tapered shape probe with the diameter of 0.7 millimeter at the tip and 1.0 millimeter at the base. So, so the probe is a tapered shape. On the other hand, MD10 has uniform diameter probe. Everywhere the diameter is 0.9 millimeter. MD10 is much more rigid than MD10. This is fine, but rigid because of the tapered shaped probe. So the lifespan is very long. And it is easy to insert to the lacrimal punctum because the tip is 0.7 millimeter. Sometimes we don't have to dilate the punctum. This is very useful in insertion to the punctum. However, MD10 has a good sheath compatibility. So for performing the therapeutic dacryoendoscopy, such as SEP or SGI, we need MD10. But for everyday examination, daily routine examination, I use MD3. This is how to use MD3 and MD10. So, what about the visual quality? Actually, MD3 has 3,000 pixels. MD10 has 10,000 pixels. But interestingly, the visual quality is not so different from these two models. Not so different. I'm going to show you the example. This is same case, intra-op and pre-op. The pre-op diagnosis was nasal lacrimal duct obstruction. This is SEP. What I'm doing is SEP. I'm dissecting the fibrous tissue around the lacrimal stent to make the lumen wider. The bigger, the better. So make wide until I can see the slit sign. And right side, this is after removing the stent, I examine this case using MT3. Not so different. Image size is bigger in the MT10. But a viewing angle is exactly the same, 60 degrees. So that's why I use MT3 in routine examination. And occasionally I use MD10 for the secondary STI. So the next one is, this is very important topic, very important. Why I choose the curved probe? First of all, I like to introduce Dr. Narioka's study using cadavers. He inserts a straight lacrimal probe from the punctum to the lacrimal sac of the cadavers and compare the inclination of the probe and inclination of the nasolacrimal duct. As a result, in 72% of the cadavers, the inclination of the probe is steeper than that of the nasolacrimal duct. So this suggests there is a risk of hitting the posterior wall of the duct when using the straight probe. For avoiding this, the probe curve is crucial. In this slide, I can show you the difference of the visual direction between the curved probe and the straight probe. This is example of focal nasolacrimal duct obstruction. As you can see, we can see the contrast medium in the lacrimal sac, and the air is coming into the nasolacrimal duct here. So blockage is just focal here. In this case, when using the straight probe, the duct visualization is like this. I cannot see the obstruction site. What I can see is just posterior wall, like this. I cannot control the inclination of the fibroscope because there is a limitation of, due to the orbital rim here. In contrast, when using curved probe, I can easily see the obstruction point. Of course, I can see the posterior wall, but I can reach the obstruction site like this. This is different. So please use curved probe. And we have the other advantage in probe curve. This is let's look at this video. When I rotate the handpiece like this, I can control the direction of the probe tip like this. This is very important. This is very important and useful in the probe insertion to a punctum or in performing endoluminal operation. I can show you the example. This is probe insertion demonstration. What I'm doing is post-operative examination. Before before inserting the endoscope to the punctum, I rotate the handpiece like this. Look at this light guide and the syringing tube here. And so the probe tip direction is to the punctum. Right after insertion, I correct the rotation like this. So in this video, I'm going to give you one tip or 1 point for beginners. When you perform duct examination, please use upper punctum. Upper punctum is very useful for get into the lacrimal sac. Through the inferior punctum, this is very difficult to get into the lacrimal sac. So please use upper punctum. And the left side video is, this is a SEP video. Pre-op diagnosis was nasolacrimal duct obstruction. I'm getting into the lacrimal sac now. And what I can see is a pinhole, which is entrance of the fibrous tissue. And what I'm doing is SEP. We can see the pinhole, so precisely I get into the pinhole like this. And what I'm doing is twisting the handpiece. This torsional movement is very important because we have to make the lumen wider, and we have to dissect the fibrous tissue to make it wider. So if I used a straight probe, this kind of movement cannot be done. And let's proceed. This torsional movement. And, And basically, for performing recanalization using SEP or DEF, the most important thing is precisely follow the ductal lumen remnant, which ductal lumen remnant is one of original tract which used to be opened, now closed. So exactly follow the ductal lumen remnant is very important. So while rotating the handpiece, I'm looking for the ductal lumen remnant. So I'm looking for the ductal lumen remnant. Where is the ductal lumen remnant? Where is it? Here. And there is a septum. There is a septum here. The ductal lumen remnant is in the septum like this. So you can see the ductal lumen remnant here. So precisely follow this track is very important. So I can summarize this section like this: MD10, MD3, and MD10. Rigidity, about rigidity, MD3 is better. Visual quality is not so different. Sheath compatibility is much better in the MD10, so I use MD10 in SEP and SGI. And I talked about probe curve. Probe curve is very important from a point of view of anatomy and handpiece control. So the next part is not so. The final section is important. Advice for beginners. So what you need for starting endoscopy? Of course, lacrimal endoscope and nasal endoscopy is required. However, more important thing is blind technique experience. If you have blind techniques experience, such as lacrimal probing or nasolacrimal intubation using Crawford tube, then you're going to get over the steep learning curve earlier. Or direct visualization is not necessarily always perfect. Then blind technique helps you. And the problem is, what is the good candidate for starting endoscopy? The best candidate is post-op nasolacrimal duct intubation, because this kind of patient has a large punctum, so endoscope insertion is very easy, and the patient is getting used to doing something inside the lacrimal passage, so patient is not so nervous. So this is a very nice candidate. So look at this. So the examination timing is immediately after removing stent, and when patient complaining of residual epiphora, then you can go for dacryoendoscopy. Immediately after removing the lacrimal stent, oftenly you can see this kind of a granulation formation inside the lacrimal passage because of the irritation of the irritation or allergic reaction to the lacrimal stent. 20% or 30% patients shows this kind of granulation. Long-term intubation has an increased risk of granulation tissue. So my opinion is long-term, more than 3 months, no. I remove lacrimal stent every day, every time on the 2 months. And this example is very interesting. The patient was coming to see me complaining of residual epiphora. Even though having a lacrimal stent, she is still watering. And nasal endoscope, using nasal endoscope, seemingly the one end of the lacrimal stent is coming from the original good track, but one end of the lacrimal stent is getting out of the false passage. So I thought one end false passage. However, lacrimal endoscope, truth is not one end. Lacrimal endoscope reveals that both end is inserted in the false passage. Original track is this one. This is original track. So lacrimal endoscope is sometimes reveal this kind of strange false passage. In Japan, dacryoendoscopy, therapeutic dacryoendoscopy, such as SEPA and SGI, is very popular and very widely distributed. So nowadays, we don't see this kind of patient. We don't see. We seldom see. But maybe in your country, Crawford intubation set is very popular, I heard. So this kind of a patient, you can see this kind of a patient. And this is the best way to get used to the dacryoendoscopy. And the contraindication include non-expressive dacryocystitis, acute dacryocystitis, malignant lymphoma. So if you can see this kind of patient, go for CT before thinking about dacryoendoscopy. And patient has a small punctum, is not contraindication but difficult to examine. So please avoid until you get used to the dacryoendoscopy. Thank you very much.